It's a really great question. It comes up every day in clinical practice. The data for TAVR keeps getting better every week. Having said that, surgical technique is also improving. Surgical outcomes are improving, certainly at high volume centers. That's what I'm really referring to. So the choice between TAVR and SAVR can require a fair amount of thought. At the extremes, I'd say it's pretty easy, or it should be. If somebody's 80 years old, they have severe aortic stenosis that's symptomatic, well, then they should get a TAVR. On the other hand, if they're young, and we can debate exactly what young is, but again, to take a more extreme, let's say they're 50, they've got a bicuspid aortic valve, well, then they should get a surgical aortic valve replacement unless there's some horrible comorbidity that precludes surgery, which is unlikely at that age. So certainly younger age would push me towards recommending SAVR. And by younger, 50, I think is pretty easy. 60, probably still, I would push for SAVR, really up till about maybe 65 or so. After that, it sort of depends. But even there, in the 65 to 75 range, if it's a bicuspid aortic valve, there, the data for TAVR are evolving. We really need randomized trial data there in larger numbers. But until that happens, I think surgery remains the gold standard. So again, if the patient's a horrible surgical candidate, if after really a meaningful discussion, including with a surgeon, they refuse a surgical AVR, then you have to do what you have to do with respect to TAVR. And TAVR, of course, has been done in folks with bicuspid aortic valves with pretty good results. But in particular, when they're very young and there's questions about durability, especially in that setting of TAVR, really I would default to a surgical aortic valve replacement still. Really, it has to be an approach of a lifetime management strategy. Can't just think of, oh, patient wants a TAVR. I talked to them briefly about surgery. They don't want surgery, of course. Nobody wants surgery. We're just going to go in and do TAVR. Really have to think about the lifetime management of a patient. So if they're young, it might be the case then that whatever the procedure is, TAVR or SAVR, at least with a biological valve, that is a tissue valve, that it's not going to last for the next 25 years, So you have to think, okay, they may need a second procedure, possibly even a third. So let me make sure I do a procedure now that still allows that next procedure to occur. So you have to really think about things like the size of the valve that's being placed. Don't want to put in a valve that's so small now it makes reintervention for that next potential procedure more challenging. So do need to factor in the patient's age, do need to factor in their comorbidities, and do need to factor technology as it evolves. The hope is there'll be even better TAVR valves, even surgical valves. There have been some recent advances, but TAVR has really been leapfrogging forward in terms of iterations of valves, with each iteration getting better. But that doesn't mean the innovation has stopped. There's lots of research going on trying to make TAVR valves even better, such as attempts to make them smaller in terms of the delivery system, such that instead of needing to really have large bore femoral artery access, that we can get away with smaller bore access, potentially even 8 French access, which there's studies going on to see if such valves will be durable. And if they are, one of the major remaining complications from TAVR, vascular complications, bleeding complications, could be markedly reduced. So at least right now in younger patients, do want to prioritize surgical aortic valve replacement. And by younger, I'm saying, less than 65. But that might change as the valves get better. But we need data and randomized data before really moving the needle too far, too quickly. So for aortic valve TAVR, the field has become quite mature, though there's still room for innovation, and indeed, it's some exciting work going on in the field. For mitral and tricuspid valve intervention, we still, I think, have a long way to go before we really find the optimal techniques for valve replacement. Certainly, the edge-to-edge repairs are very effective for certain subtypes of tricuspid and mitral valve disease, especially for mitral valve disease. But even there, one needs to think carefully about many things, about imaging the patients, making sure that their valve is really suitable for that type of approach, making sure their medical therapy is maximized. Certainly, it does seem like transcatheter edge-to-edge repair and its necessity is somewhat diminished if one is employing optimal medical therapy for heart failure patients that have mitral regurgitation. The data are pretty clear about that. That's also true with the tricuspid intervention where great medical therapy can help, maybe a little less so than in the mitral circumstance. So lots of different cardiology input is needed, that input from imagers, the input from doctors managing patients medically, and that affects the need for such procedures in the first place. As well, it does seem that volume matters, so doing these sorts of procedures at higher volume places does seem to be the way to go. Maybe as the technology gets more mature and easier, that may change. But as I mentioned, it's not just a matter of the technology or the operator. It's also a matter of great imaging and great concomitant medical therapy. Tricuspids in particular, I think, are very challenging. The surgery there has been problematic because those are often sick patients. They have bad tricuspid regurgitation. Sometimes the liver's in bad shape. They may not do well with prolonged anesthesia. Recovery, even after successful technical surgery, can be problematic. So transcatheter approaches are particularly appealing for those patients that are often really bad surgical candidates. With mitral valve surgery, if a patient's a great candidate for mitral valve repair, at a high volume, good center, it's hard to beat. The complication rates are extremely low. Some centers reporting, mortality that's close to or at 0%. So very hard to beat that. But those are typically, younger, healthier patients, not somebody with heart failure and secondary mitral regurgitation. So patient selection is important. Really, a multidisciplinary team needs to care for these patients. And the innovations that are yet to come in terms of valve replacement, I'm really excited about, but we just need more data before broad adoption of the valve replacement technologies for mitral and tricuspid valves. Well, it's got to be individualized in all these decisions that we're discussing here with respect to TAVR versus SAVR, surgery versus percutaneous approaches for tricuspid and mitral valves. All these things do involve shared decision making, but it should be informed shared decision making and a realization that sometimes a surgical approach still in the current era remains the best. When a patient has failed TAVR, that can be really tricky, and that number of patients is growing just because the number of TAVRs has grown, and the number of patients with prior TAVR is quite large now. And options include a redo TAVR, that is a valve-in-valve type of TAVR. In TAVR, it can be valve explantation, which historically had been really tough surgery with bad outcomes. It remains tough surgery, but in some respect, at least at high volume centers, the number of valve explants is going up. So surgeons are getting a little bit better at that, I think, which is probably good for patients who need that sort of procedure. And sometimes putting in a plug can do the trick if there's a paravalvular leak. But how to do that, will depend on the patient, will depend on the imaging. That's extremely important to have an imager that really understands structural heart disease intervention. And then, the best sorts of decisions can be made, again, factoring to an extent patient preferences, certainly patient comorbidities. But TAVR, in TAVR, certainly many reports of that being done successfully. But valve explantation sometimes does have to happen, especially if there's infection or other circumstances that preclude placing another TAVR in the prior one. So really want to get multiple sorts of opinions, not just the interventionalist, but the surgeon and the imager and just the cardiologist managing the patient to put their heads together and then discuss with the patient and come up with a solution.